All right, well, ma'am, you okay? You
I'm
all right?
good. I'm good. I'm walking my dog.
Okay. All right, you sure? Look like you were starting to slip a little bit. Is your arm okay? Ma'am?
Take your mask.
Okay.
No,
All right. All right. So it looks
but
like
I want to walk my dog.
All right, ma'am. Okay. All right. Well, we're gonna ease you down, man. We're gonna ease you down to the ground, man.
Okay.
Are you
Is
having
my
trouble
dog
standing
down
up?
here?
All right. Let's ease down. We ease you down to the ground, man. All right. Look around and see if anybody ever call for help. I'm gonna check to see if she's breathing. She's breathing. Looks like her arms limp. I'm gonna call for help. Check your pulse. You okay? You all right, ma'am?
I'm good. I'm walking my
Are
dog.
you sure? Okay.
So,
We're going to the park.
All
so
right.
what makes you think something was going wrong with her?
Well, her speech started to go away, slurred speech. Obviously, something's changed from her, she started to lose her balance and everything. Facial drooping on one side, her arm starting to go limp. So we don't know if it's a stroke, but I'm going to assume it's a stroke just based off EMT. That's what we were taught. So I got her out of the vehicle, called for help. When help's arrived, obviously EMT is going to load her up in the ambulance. And about as most of we can do as EMTs, once the hospital, is just going to keep reassessing her O2 and transport until we get her to wherever she needs to be. While obviously keep reassessing vital signs, checking the glucose and making sure she's stable, until we make it there. And then once she gets to the hospital, that's when they'll do more stuff. And also the time as well. Make sure you document the time. You know what time the symptoms started. That way when you get there, that's very, very important for certain medications and everything for when she gets to the hospital.
Okay, thank you so much. Good job.
Thank you.
Dr. Johnson is going to continue this process. Like I said, timing is very important with stroke. It makes a difference between paralysis and recovery, and also between the difference between life and death. So he's going to take it from, he at the ER right now, and he's going to receive this patient, and he's going to continue that care process that Davis has started. Okay? Thank you, sir.
I didn't know I was role playing. Okay, so the pertinent things about stroke. What are the two types of stroke? You know what I mean? Right, so you can have a bleed or a clot, right? But in either case, blood doesn't make it to the cells, which is why you get altered. Can you tell if she has a bleed or a clot just by looking at her? No, you can't. So what's the first thing you got to do when they get to the emergency department? You got to look, right? You got to look inside her head. So the only non-invasive way to do that is to scan her head. Because the medicine I need to give you, the one that he was talking about, is if she has a clot, I need to bust that clot up, right? But if she has a bleed, that's just going to make it worse. Does that make sense? Mm-hmm. Right? So you can't just guns a-blazing and give them medicines. So that she gets there, you think she's having a stroke because of whatever signs and symptoms she has. What is your priority? Okay, it's important to know, but what else is your priority?
What type of stroke that she has?
Don't care. Yep.
Yeah.
Okay, so here's the thing, and here's what everybody screws up. Whether you got your finger sticking out to Mama's house because you were in a trauma, or you got a knife in your eye, or you have a stroke, those are distracting things, right? You're like, yeah, facial droop, she's having a stroke, let's go to the scanner. But if she dies in the scanner because you didn't protect her airway, that's a big problem, right? So you need to put it, so when people are panicked, they default to what they know at their core. So you need to put in your core ABCs, period. Because I have seen numerous stroke patients die on a scanner because their stroke was evolving and they stopped breathing on the scanner because everybody was so interested in seeing what was in her head. Does that make sense?
Yes.
All right, let me ask you this question. What if you woke up with symptoms? Last seen normal going to bed last night at 10. And I woke up and I can't move my right arm.
Last seen normal was 10 o'clock.
So do I get drugs? What's the time frame for drugs? Let's put it like that. So you got 3 hours. So that number moves all the time based on whatever the academy of whoever sits down and talks about it. So, but right now it's 3 hours. So I got 3 hours from onset of symptoms to give you medicine. If last seen normal was at 10, what I do? I'm out, right? because the risk of converting you to a hemorrhagic stroke is way greater. Does that make sense? Now, I will also tell you, if you get the medicine, there's a 50% chance that you're probably going to get a hemorrhagic stroke anyway, because it's busting up clot. Yes? So in my personal opinion, if I wake up and I can't move my thumb from my stroke, leave me alone. I'll just deal with my gank thumb for the rest of my life. Does that make sense? But if I can't move one side of my body and I am completely dysfuncted, then I'll talk about it at my age, right? Also, if I'm 97 years old, I don't know that I want my grandmother getting TPA, right? Because there's a chance it'll kill her. Does that make sense? Okay. I need a bald head.
You got one right here, buddy.
All right, I can say that because I have a bald head. All right, stand straight up. So there's two ways to get blood upstairs, right? You got a posterior circulation that goes through your neck, and you got an anterior circulation that goes through your carotid.
Oh, sorry.
Okay? But each part of his brain does something different, right? Your personality, your sense of humor, all that stuff. If I found a stamped envelope on the sidewalk, what did you do with it? I'm asking. You found a stamped, addressed envelope on the sidewalk, what would you do with it? So that decision comes from your frontal lobe, right? Just simple, anybody above the age of 5 would do that, okay? Then he's got a band of neurons right here, like a headband, that controls whether he can move his arm or not, okay? In the back part of his head is his vision, and then every brain sits on a stick, which is your brain stem, which controls your heart rate, your blood pressure, and all that kind of stuff. Does that make sense? So if he has a clot in his carotid that gets sent up, it's going to land in a different spot than, per se, it came back right here. So not everybody's going to have facial droop. Not everybody's going to have one-sided weakness. Some people might think they're just walking their dog. Why? Because whatever part of their brain does not get oxygen, that's the part that's going to have symptoms. The textbooks will always tell you, well, look for facial droop and one-sided weakness and all that stuff. Yeah, that's great, but you have to have it in the right spot to do that. Does that make sense?
Yes.
So because you can't see in their head and you don't know what kind of stroke it is, you have to ask them questions. So anything abnormal, right? Now, what is the last question she will always get right? So I can ask her a plethora of questions. Do you know where you are? What day of the week is it? Blah, blah, blah. But I'll tell you this. If I work 5 days in a row and I'm on a car wreck, don't ask me what day of the week it is. I don't know. Especially if you work night, right? Because now you flipped into a new day, you know, your circadian rhythm does something. So if I'm in a car wreck, I just know I have to go to work 3 more times, right? I don't know what day it is. So that's a stupid question to ask me. What's even dumber to ask people is, what is your name? Because that is the last thing you will ever forget. Everybody knows their name, but they don't know their environment, they don't know the calendar, what's the most recent holiday, that kind of stuff, okay? The other thing about when you come to the emergency department, if you don't know your name, are you having a stroke? No. What's your sugar? Right? I start forgetting stuff if I hadn't eaten lunch, right? So there's other things you got to check. What's their oxygen level? What's their sugar? Are they on medicines or drugs? Whatever. That stuff can alter your sensorineurosis too, okay? When you do this left-sided weakness business, you get anchored into thinking they have a diagnosis of stroke, and that's not necessarily true, okay? So I had a guy come into the emergency department once, and he was 27. And he had mustard caked on him from head to toe on his right side of his body. Because he woke up weak. Now, last seen normal was like at 5 a.m. when he stumbled into the house. Okay, so we're within our time limit. But he comes in, he's got mustard all over himself. And we scan his head, and sure enough, he's having an embolic stroke. So we give him TPA, and his function comes back. And we get to, so that begs the question, why do you have mustard on you, right? And he said that his mom told him that whenever you have a little bit of weakness, if you put some yellow mustard on it, then it'll so he emptied a jar out on himself. Now, when we gave him TPA and it worked, what do you think worked? The mustard. So I'm here to tell you officially, the FDA has never approved yellow mustard. Does that make sense? All right, last thing, GCS. Right? Y'all know what GCS is? Y'all do it as ZMT, kind of whatever. Okay, so In my opinion, GCS is stupid, right? Because why was it invented? What's it called? What's GCS invented? Glasgow Coma Scale. And where it was, if you look it up, where it was invented is in Glasgow, Scotland. And it was a measure to see how well people were coming out of anesthesia, right, after their surgery. So it would make sense. As the anesthesia is wearing off, I should be able to do more stuff. My score improves, right? We don't use it for that, do we? We tell it, how sick are you, right? So it's based on your eyes open, can you talk, and are you making sense, and can you move your muscles, right? That's the three big questions. Okay, well, let me ask you this. I'm Mr. Jones, and I come into the emergency department. He's like, hey, so I was working out in the yard, and I felt some weakness. Now, obviously, I'm looking at you. Eyes are open spontaneously. I make perfect sense. It's Saturday. It's April, whatever. I'm perfectly oriented. And when you say, hey, can you shake my hand? I absolutely can do that. So I got a GCS of 15, right? And ain't nobody talked about the right arm I can't move.
Mm.
You follow? So GCS is telling you the wrong information, right? And then let's see what else. Oh, okay. Squeeze hard skin. Okay. Now let go. So she's got +3 strength. How strong is she? How do you know? You chart it all the time. You put it on the record. They got +3 strength, whatever. So here's what needs to happen. Come here. Squeeze his hard skin. Now let go. Now squeeze him as hard as you can. That's what I'm calling +3 strength. Okay. So when he goes through his shift later that day and she's less than that, he now knows. Does that make sense? Mm-hmm. So when you give handoffs on neuro patients, you got to do it kind of face to face and say, hey, Mr. Jones, what's your name? And they don't know. No, you got to get in his face because he's an old Vietnam vet. And he can't hear. Okay, and let me tell you this: as you lose your hearing when you're an old guy, you lose high frequency first. Right? So you can hear real low frequency, which means they can hear guys talk, but they don't really hear girls talk so much. So it's not that you need to be louder, you got to be lower. Right? Hey, Mr. Jones, what's your name? Like that kind of stuff. Not loud, because he's not deaf, he just lost his high frequency. And it's the same thing downrange. If the bomb goes off and they got tympanic membrane rupture or whatever, you can still hear. What does your eardrum do? It just buffers sound waves, yes, but it doesn't mean you're deaf if it blows out, right? But you may lose high frequency loss. So when you got your patient in front of you, you don't need to yell at them. You need to change the frequency of your voice. Does that make sense?
Yes, perfect.
Okay.
Yeah.
So you got to ask questions, knowing that they're going to remember their name all the time, right? You've got to standardize your exam so that he knows what I'm talking about. Because the worst thing I could do is say, so yeah, she's a stroke, I gave her some TPA and she'll be all right, bye. And then he's going to go back and read my chart and say, well, he charted that her grip strength was 3+. What does that mean? Maybe he's stronger than I am. Maybe he's got more fingers or he does it a different way. Does that make sense? And you've got to know what you're testing. Just because your nursing school or EMT school or the book or whatever says GCS and AO times 3 and all that crap does not mean it's applicable. Right? GCS, yes, can give me a good idea. If I told you I'm coming in hot, red, sirens, everything, and I got a GSW to the chest with a GCS of 4. Is he sick? Yeah, right? Like that's it's helpful there. But if I'm talking about this person who's got an isolated weakness to an arm or whatever, and their GCS is 15, you're no smarter than you were 5 minutes ago. Right?
Yes.
Okay? The book teaches you textbook, like how everybody should present, and that's the rule of thumb, is nobody presents according to the textbook. Nobody does. Okay? Make sure you rule out other reasons to be altered. Sugar, oxygen, they got drugs on board, whatever. And you can't give them medicine until you know what's in their head. So you got to scan them. So what do you do in the field? TCCC folks, if you grab somebody off the street or off the ground or whatever, and they're altered, how do you know? You don't have a scanner, so why is that not important right there? Because what's important right there is airway, breathing, circulation, right? And if you came into me and brought me a patient who's tubed and lined out and said, look, before I tubed him, he was super altered and he wasn't really moving his left side, but his airway was a threat, so I took care of that and I got him some blood on him. Like, I gave him some blood. Ain't nobody gonna fault you. Because you don't have the capability to figure out if he's having a stroke or not. That's what we're here for, because we have all these resources, right? But you've got to do stuff in order. And if you look at any trauma protocol, it's actually A, B, C, D, right? Airway, breathing, circulation, and then disability is the neuro stuff. But when you come in with yellow mustard, that could be a little distracting. Does you get it? So you're going to want to rush off and think in your little toolbox of neuro stuff. I want to scan him and give him some TPA or whatever. Point of fact is, you got to make sure his airway's okay, his breathing's okay, all that kind of stuff. Questions? And I was like rapid fire, but that was off the top of my head, so I don't have a PowerPoint to give you.
Good.
Okay?
That was awesome, sir, as always. Thank you so much.
No questions? All right. Anything else you want from me?
That's also, that's excellent. Thank you. Thank you for your time.
The only comment, I'm glad you said that about the like the hearing and all, because that explains why the men don't listen to their wives.
Probably.
Yeah.
And there's no way to prove it either. So if I say it, it's the truth.
Okay, Stuart.
But the VA is full of it. If you ever get a chance to work in the VA, all those guys can't hear. Now, it may be selective or whatever, but you always have these like little female nurses come in. Hey, Mr. Jones. He couldn't hear that if it was standing right next to him because he's not had high frequency hearing for the last 40 years. But if you get right next to him, real kind of quiet, but low, and that's why the guys always work, he'll pipe right up and tell you 15 stories about his wartime and blah, 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 blah. I'm like, how'd you do that? It's not because he's being an ass, he just can't hear. Right? Okay.
Thank you, sir.
All right.